what we didn't anticipate is how economically things have shoot up when it comes to prices. And we feel that it was not actually fair enough for us to charge a huge amount for people to come to a face-to-face in the current climate. Hence, where we had to now opt back to a virtual meeting. So we are doing what we can to see how we can put things together so that we could do a face-to-face, but not putting so much pressure financially on everybody else. So hopefully watch the space for us to be doing one sometime early next year. So, okay. So just going through a brief on the agenda. So as you can see, we've got a lovely agenda for the next 2 hours. So I know some people will be able to stay for the whole meeting, and that would be wonderful if you're able to do that. But we know some people might have other commitments they had to drop out halfway. So we still appreciate you taking time. What we're aiming to do as well is have the opportunity to ask 1 or 2 questions after each speaker, but trying to keep as much as possible to our timings. And hopefully at the end, if we get a spare 5 or 10 minutes as well, just pick up some few questions again that might come up through all the presentations. What we usually do is always upload our webinars or meetings that we can onto the PPLOG YouTube channel. So hopefully if some of your colleagues didn't manage to join today, you might be able to signpost them. And it's all, you just need to go on the PPLOG website and it will just see the YouTube channel. And when you click that, you will see the PPLOG recordings or anything that we've done in the past, we upload it on there. Okay, so as you can see on the agenda, it's a nice packed agenda, but very informative. And our first presentation will be by actually me and Moni, and we'll be talking about the NHS London service specification. We've worked with Moni from probably day one of how we're doing with she probably is a member, she doesn't know that she's a member of the Pediatric Pen London Oxygen Group, I would say, because we've been working together on this for years and years and years. This is through the wonderful introductions as well from Caroline Locke, who's our, air liquid specialist nurse, respiratory nurse. So Moni is very vital and pivotal to some of this work and how we've been pushing forward in actually getting that strategic support in how we move with PPLOG, because a lot of the things we did was very operational, but we started pushing it from a strategic, getting that involvement and sign off from different organizations and senior leaders. So I'll just do a quick introduction on that. So this London service specification, we launched it early this year, around May, if I remember, 26th of May, not that I keep dates. And when we launched that, was a response to some of the feedback that we were getting about, we tried to address it from a Pediatric Pen London Oxygen Group, addressing the variation. But what we were trying to do with the service spec was now actually create how we can have groups or individuals that are sitting within systems, especially your integrated care systems or within your trust, to actually be having the oversight of what is happening within your area. Currently, that doesn't happen within children and young people services in oxygen. This has been ongoing service that has been happening in adult home oxygen services. So that's why this was key for us to start working on this. So what we did, we looked at what was happening and what the data was saying. So this was some data that we looked at, and we had seen data over the years, but some of the data we looked at was from March 2022. And one of the most common things that we noticed on that, through that, was that chronic neonatal lung disease was one that tends to be one people prescribe oxygen for. And there's so many things people keep on saying other conditions. Until now, we try to figure out what is other conditions, because there is that element where you tick a box and say we are prescribing oxygen, other conditions or other primary conditions. So those 2 areas are things that we hope in the near future we can do a deep dive to actually find out what are those key things of the other conditions. So as I already highlighted, so when we did that, it then got signed off because we wanted to make sure that it's just not us as a Penn London Oxygen Group saying this is good and this is going to work, but we wanted to make sure it was reviewed by key people that have either the expertise or the knowledge around home oxygen or oxygen for children and young people, or have the strategic input on how to commission these services as well. So there were those elements to think about. So it got signed off by the London Respiratory Network, which is an oxygen working group that we sit as PPLOG, and that is focused on the other oxygen groups, but we had the opportunity to be part as a member of that one. Was also signed off by the London Clinical Advisory Group, which is part as well of the North Thames Pediatric Network, and the South Thames as well, reviewed and signed off. And it was shared for ratification as well with NHS England, the London Children and Young People. So it was key for us to make sure that we had the right bodies and the right people, organizations to support this. I think, yeah, so I'll just do that and then I'll head more to Ed. So as you can see, that was the scope of that provider. And it also highlights, you know, when we talk about it, having somebody who sits, as I said, in an ICS level, your integrated care systems, which has just been launched this year, and there was so much talk about it, but having a named individual who currently right now, whenever we try and ask for information or try and get clarity in a certain area, there's various people that we need to talk to. And sometimes some people will say, actually, this is not really our remit, even though we look after these children, but we just started taking those cases because there was nobody else picking it up. And some will say, actually, we can only look after them, but we don't prescribe oxygen. So we see so much various information every time we start dealing with oxygen, either information or escalating of these concerns that have been highlighted. So hence, this is key. So not currently, this doesn't happen. So this is why there's a service specification, is we are trying to encourage and work with different senior leaders to see how we can get this implemented. So that is about giving that professional expertise and leadership support to professionals who are caring for those babies, children, and young people on home oxygen therapy. Ensure that there's a clear governance. Who do you report to in your area when you have challenges and you don't know where to go and you're worried about a certain case or you were trying? We've been receiving numerous emails and sometimes phone calls to actually ask for advice regarding clinical cases. And in all honesty, we do our best, but what we have recognized is we are not the expertise because we cannot see that child, we cannot see the situation. And actually, the other thing is we are quite worried that we're giving clinical advice in cases where you need somebody who's got the expertise, in the sense of somebody who's sitting within your area, who then we can equip with the knowledge and skills and say we will support them, but they can actually either come down to your unit or drive down or have a meeting with you or join your discharge planning meeting, all those little things that can support you when you are feeling challenged. So we are hoping that's the future, that's the aspiration. And that they are also, as I said already, a point of contact for you. I think I should be handing over to Moni.
Yeah, thank you, Tendai, and thank you everybody for joining. My name is Moni Abiola Pella. I'm the operational lead for the London Home Oxygen contract. And just continuing with what Tendai has been saying, you know, across London, there are a lot of teams, there are a lot of pockets of good practice with, you know, pediatric home oxygen. I say pediatric, but I'm referring to, you know, babies, children, and young people. But a lot of pockets of good practice when it comes to managing the home oxygen in the community. But there are also a lot of areas where there actually is no service or no process at all. And what we're trying to do with this spec is, you know, bring all of that good practice together, identify where there are gaps, and we've put together this service specification that can act as a tool to implement a kind of service or a process, as Tendai has explained, so that we actually have named leads in each of the ICSs, or we have teams who are able to deliver a full service in alignment with this service specification, bridging all of those gaps that we've noticed in the pediatric home oxygen environment. I mean, looking in the chat, there's been a lot of introductions and there's a lot of people from various different community teams. I've got, you know, we've got people from hospital, community teams, from schools and so on as well. And as you can see that children and young people that tend to need home oxygen, they have quite complex clinical needs, and they tend to be under a lot of different groups or a lot of different, teams within the community. And what this spec is trying to do is trying to bring all of that together and make sure that there is no gap when it comes to their home oxygen therapy, to make sure that we actually have named healthcare professionals to take forward the care for their home oxygen, or to act as a guide for those teams that are already looking after the patients, so they feel empowered and upskilled to be able to manage the home oxygen requirements for the children in the community. And what it is that we're not looking for HOSARs to actually become the named owner or named clinician per se for patients that require home oxygen in the community, but it's about being a part of that MDT that looks after that patient. So any patients that should be coming to the HOSAR service or the community team that looks after the oxygen, they should be patients who already have a diagnosed clinical condition, and they should be under a named clinician, either in secondary or tertiary care. And the HOSAR is just helping with the monitoring, any kind of assessments and reviews linked to patients' home oxygen therapy in the community, to make sure that there are no gaps in that patient's full journey of care, including their home oxygen. Tendai, next slide, please. So this is just an overview, providing some kind of a bit of a summary of what's actually in the service specification, in what the kind of expectations or the asks are for pediatric HOSAR services. And as I just mentioned, it's to provide the assessment, monitoring, and reviews of patients in the community who have home oxygen in place. And also, it's also to act like a support system to secondary, tertiary care providers and other community teams who are dealing with patients who also have an oxygen requirement, so that the best skilled person is actually inputting and looking after that patient's oxygen to make sure it's better optimized and it fits in with their whole package of care. It's also about ensuring that where there are pathways and guidelines, they are being followed. So the PLOG group have produced a lot of fantastic documents to help with, the use and prescribing, the discharge of patients on home oxygen. And it's about making sure that these are being followed so that there actually is consistent practice across the whole of London. It's also about prompting teams to make sure that patients actually have their home oxygen prescriptions reviewed. Because as we know, a lot of patients are started on home oxygen and that's it. Nobody takes on their care, nobody reviews their oxygen, and it just carries on like that. And actually, they might not need it anymore, or it might need to be optimized, but that's not happening. And by having the HOSAR in place, they take on that role in terms of looking at the data and making sure that patients are having those reviews, or prompting the teams that are due to do those reviews for the patients as well. Also, it's about incidents happen, in all services, and it's about where there are incidents in home oxygen, that they are being investigated, they are being reported where they need to be to the right forums, and actually any learning is shared as well. Because obviously when there's an incident, there needs to be a root cause analysis, and there will be learning from that incident. And it's about sharing that best practice across other teams as well, so that we can change practice, but we can also learn from it and prevent it from happening again in other teams as well. There is a lot of data linked to the concordance of patients when it comes to their home oxygen, and that's available on the Air Liquid portal as well. And the HOSAR will be a part of the service who would look at these reports, look at the monthly invoices as well, and address any areas of concerns, be it directly with the patients, or escalate them via the right routes, which could be, through myself and my colleague Karen as the contract managers with Air Liquid, or just it might just be a case of actually reviewing a patient following a review of the concordance report. So these are some of the key things that we would expect from a HOSAR service once it has been commissioned. Next slide, please, Tendo. And the good thing about this service specification, we have one for adult services, but the pediatric one is all singing, all dancing. I think it includes everything that you need. It's not just about what the HOSAR service should do, but it looks about the other elements of pediatric oxygen care in the community. So a lot of patients will also need oxygen at school as well. And the service specification talks about how you would go about setting that up, what you need to consider, who needs to be involved, who needs to be trained as well. And I think that's really useful to have, because without this service specification, I think a lot of teams won't know what they need to do when it comes to setting up an oxygen account, and who needs to be involved in that, who needs to be trained as well. It's got a fantastic flowchart in it as well that talks about the transition of care from the pediatric to the adult service. I think if you look at the spec, I think it might be on page 15, but it gives you a bit of a chart to show what needs to be considered, what needs to be reviewed, so that the patient's oxygen care is best optimized and it's ready to be handed over to the adult service as well. Because a lot of times you find where patients haven't had a designated or named team or healthcare professional in the community, their oxygen sometimes isn't reviewed, it's not optimized, and they kind of automatically go into the adult service as a kind of problematic case of care. But actually, if that's addressed before they transfer, they get more out of their adult experience with the HOSER service as well. The spec also includes, I think, 2 weaning guides as well, dependent on oxygen flow rate as well, which again I think is really good, and that helps ensure that where patients are weaned, there is guidance. Because speaking to some teams, they're happy to do it, but they just don't know how to. And having this in the spec is really good as well. It gives you quite clear instructions, step by step, as to how to wean a patient down from their flow rate to no longer needing oxygen or to needing a lower flow rate of oxygen as well. Obviously, we're in the RSV season now, so I know a lot of you are aware of RSV cases, and I think it's one where it does require experience and care when it comes to using oxygen in RSV, because there does tend to be some inappropriate prescriptions of oxygen for RSV patients, but sometimes there's also appropriate oxygen, but it's left in long term when actually it should just be short term for that RSV period, and then it should come back out. So this spec includes some guidance on managing oxygen for patients in RSV. And a very, very difficult element of dealing with patients with home oxygen is removing the home oxygen when it's no longer required or when there's no longer a clinical need. And there does become, attachment and dependence on home oxygen. And the service spec does give a lot of good tips on how best to remove the oxygen, because we appreciate that it's a very difficult step in removing the home oxygen, but there's a lot of good guidance within the service specification. And it also includes escalation care plans, which are quite important to have in place, and performance indicators. Next slide, please, Tendai. So in terms of putting the performance indicators together, we actually had a look, or the team had a look at the evidence and had a bit of a gap analysis to identify where there were gaps. And the performance indicators were set to address those areas where there are gaps. So they were put together so that you can kind of work towards achieving the threshold that's been put in the service specification. We appreciate that where there aren't any HOSER services, starting off, it might be at 0, but it's work in progress. It's working towards, achieving that threshold and bridging that gap that exists in the pediatric home oxygen community service. Tendai, I think, is going to go on to talk in a bit more detail about those KPIs. But again, by talking about it and by measuring it, we can identify what the pinch points are or what's missing, what the system needs to be able to deliver a better service to the patients in the community and, achieve those high thresholds for the KPIs. So I'll hand back over to Tendai to talk about some of those KPIs.
Thank you very much, Moni. Yeah, so as Moni has highlighted, so these are the KPIs that we thought about, and when we looked at the evidence and that was highlighting, and one of the things that we thought that was really important to focus on, as you can see, looking at the percentage of babies, children, and young people that will be prescribed oxygen therapy, we have been followed up at home within the 24 hours. We know there's variation of practice across England right now, or even outside. But what we were trying to do is actually the safety of the patient. Is actually, how do you know that they're safe enough? If you're lucky enough, you can go after 2 days, they've been discharged, or 1 week, and things went very well. But actually, there will be some cases where you turn up and probably parents didn't put the oxygen on, or there might have been some challenges, or they might be so worried about many other things. So this was one of the things that we thought would be really key. So, and as well, the percent of children and carers surveyed and that they were happy with the care that they received. As well, those that have been trained, we're going to have Mira also talking about smoking and oxygen, but actually we do not have the data to actually know how many community or trust-based nurses or consultants that are working with children with home oxygen have actually had training about very brief advice for smoking cessation. We don't have the evidence, and I can bet you most of us, I know I did the training years ago, but actually after that, nobody actually questioned if we needed an update or if it needs to be done. So I know some people have never had the training. So I think it also asks about, do we actually talk about, a smoking cessation to our teenagers or adolescents, or as well to our carers, our parents that are looking after their children? Hardly do we mention that. And if we do, if they say something that we don't know what to do with it, we don't know where to signpost them to. So I will leave that. Mira is going to give us more insight from her expertise and skills. But as well, so you could see that one of some of the things that we highlighted as well. Expected impact and outcomes, as you can see, these are some of the things that we highlighted. Reduction in respiratory mortality, as you can see, inappropriate prescribing. You saw at the beginning we highlighted the other conditions. What are these other conditions? And and it probably we're trying to see how we can look at getting funding to actually do a big research on some of these things, because there's so many things that are happening that we think actually we need a bigger deep dive, but need a big research team to help us push this forward. So it's something that we've been scoping quite recently into that. But there's most of things that we need to ask ourselves. And as well, are we having the reduction in hospital readmissions and some of the things? So we're hoping that's what the service back could help us to achieve. Just going to touch a bit on some of the data. So these are some of the data just to highlight. So 2019, as you can see, the amount of children, and this is London. Unfortunately, I know we've got people that are joining us from different parts of England or even outside of England. But one of the things to highlight is we can only have this data because we've been fortunate enough to be working so closely with Moni and as well with Caroline, because they come from different organizations, are able to tap into that information and that data to support us to be able to achieve that. So I really recommend, and this is one of the things that we're saying, is we're really trying to see how we can support other regions to actually get a group and a team that we can support to actually start putting on, actually saying, what is your region doing? What is your data saying? And how you can capture that. So at the present moment, we can only share London's data. And you can see the amount of children that are on oxygen, discharged on oxygen within London is quite a big number. I think sometimes we just say, oh, it's a small number. It's a small number based on your hospital, but when you take it into a regional perspective, it's bigger than what you think. And then looking again at that numbers, we then break it down into one, the locations where they are as part of the region in northeast of London, northwest of London, southeast of London, southwest of London, north central, and then there are various conditions. And you can see in other areas, they've got more numbers. You can see this is one of northwest. They've got lots of chronic obstructive pulmonary disease. And then you can see in other areas, it's less. So I think there's a piece of work to be done in looking at, what is happening in one area? What can we learn from that? What could be the reasons why you've got bigger numbers in one area? And some areas, as you can see, northeast, you've got a chest wall disease, again, another big number in one area of, of London. So I just think, to me, it just gives me that curious mind. And I'm going to talk about, I think, on the last slide. So I'll move a bit faster. But this is just highlighting, and this slide as well, you'll be able to see them. You'll be able to go through them either through the recording as well as the slides. But it's just highlighting some key information. I don't want to go right into that, but I just wanted to highlight as a summary of actually looking at it and actually asking ourselves. So one of the things that has just recently been published, as you will know, is the site decided not to come on there. So there has been a publication of the NHS England in reducing health inequalities. So they've just produced and published a children and young people, the core 20+5. Unfortunately, we do not have oxygen on that. But what we have on that, it highlights very clearly that asthma and many other things. But one thing I want to focus on is the core 20. So the core 20 is the 20% of the most deprived that we need to think about, we need to consider. And one of the things when you think about our children and young people that are on home oxygen and some of the conditions they're in is actually in your area, that's where the service spec will be very supportive in that quality improvement and looking at some of those challenges is why do you have more certain conditions and where do they live? Which postcodes are they sitting in? Are they in one of your most affluent or most deprived? What are the factors that are contributing to that? And what are the QI, the quality improvement work you could do to improve some of those things? So I think it's just things, those key nitty-gritties that we're sort of encouraging that people need to start thinking about. And hence why we're talking about quality improvement, talking about looking into that, auditing your data, knowing what your data says, and who is mostly affected. You might have one or two that might go in a certain area, a certain postcode, but you might notice that there's an increase in a certain geographical area within your area that are seeming to need more oxygen. Why is that? And what condition on oxygen do they need? We might not have all the answers, but it's a start. It's a baseline to understand how do we support and what things do we need to put in place to improve some of the outcomes for these babies or children and young people on oxygen. So just to conclude before I hand over, so what is it that we're trying to say? So from that is encouraging equality impact assessments. If you haven't seen or you haven't done one before, happy to signpost you, health, especially the Office of Disparities, which was formerly Public Health, has done lots of work, and we're happy to do one. And I can signpost you some training on that. But it's really key because whenever you start a new service or you're doing any changes to a service, it's good to have an equality impact assessment because you know that is there disabilities, is there ethnic groups or gender or anything that is done with the demographics that you need to consider. And then actually part of it is when we talk about the service pack is we're encouraging local action plans. How do you improve that? So what is it that you need to, what actions do you need to consider taking? And then we're thinking and working on the support, that clear guidance that has already been created, but who is actually taking the responsibility and accountability for these children? Right now, when you say, actually, we no longer need oxygen, who actually then makes sure that oxygen is removed? Who makes sure that if it stays there for another month or so, who goes back to check that it gets removed? So many various things. And if they come from a tertiary hospital to your local hospital, who makes sure that information is handed over and then picks it up? So all those nitty-gritties. So any other things about guidance and documentation, you can find it on the PLOG website. But I always like to leave with this is, the aim is for better services, better experience for our babies and children and young people, as well as the parents, and as well for you health professions. It is so frustrating and time consuming when things are not done right, because you spend more time dealing with one case than for you to have dealt with it easily and move on to another case. So this is some of it to try and support you, that you don't spend hours or days and weeks solving one problem that didn't need all that much effort when there was already some support you could have got. And we then improve the outcomes for these babies and children and reduce the variation. So thank you. Any question, I'm happy to pick up, and Moni, one or two questions before I hand over to Gemma. You're all happy with the service spec, my assumption. It is so much information, I do understand. It is there on the PLOG website. I will ask one of my PLOG members who's probably in the background to probably put the link to the website where you can see the service spec in detail. Yes, Mira.
Hi, thank you. It was really, really excellent. It's quite interesting, and Emma, we talked about this in my smoking kind of cessation program thing within club today. But like when your graph was really quick, but it's really, really important. When you had your graph of what are the most reasons, and then where are the inequalities, you have to kind of look at it in terms of neonatal chronic and also COPD. Smoking is very much of, mothers who smoke. There is more prevalent of children having a chronic lung disease, prematurity. COPD, we already know 80% of the time, is because of smoking. So, and these are the times, these are the ways that we already know this of the lower socioeconomic background families will smoke more. So it's not a rocket science to kind of see where this is coming from and why is it important to include the smoking cessation in that, so well done.
Yeah, thank you very much, Mira. Yes, I think that's key is, we know that sometimes the situation and circumstances, and actually there's evidence as well within maternity as well, again, about, the 20% most deprived, that there's ISR increased of smoking as well within those areas. So that's key. Thank you, Mira. I will hand over now to Gemma. So Gemma is going to talk to us about her role as a allied health profession. She's based in Royal Brompton, and she's done so much great work in the past, period in trying to, do some work in improving as well the pathways and the processes of home oxygen for children and young people. So I'll hand over to you, Gemma.
Thank you. Do you want me to share my slides?
Yeah, happy for you.
Oh, no, if you've got them, then that's fine. Lovely. So hi everybody. So the people that I don't know, which is probably lots of people on the call, my name's Gemma. I'm the therapy lead in the adult team at the Royal Brompton. And part of my role is to oversee the oxygen service at the Brompton. And the oxygen team covers adults, but also paediatrics. So I'm coming at this from an adult therapist. I'm a physio by background and have been for many years. And I've ended up here today after reaching out to Tendai for some help and a bit of a chat about how we could potentially link up some of our challenges with regards to oxygen for the children and young people services coming out through the Brompton. And she suggested sharing some of my experiences here. So bear with me. So this is me here. So thanks, Tendai. So if we can have the next slide. So looking through the attendance list, it's really quite apparent that the majority, it feels like, of clinicians looking after children and young people on oxygen come from a nursing background, whereas from an adult perspective, there's a much more even split between adults and between physios and nurses. So for people who aren't potentially so aware about the role of physios and why we've got quite a good skill set to care for patients with oxygen and complete the assessments, is it's really embedded in our training. So we have a really extensive cardiopulmonary anatomy and physiology components to our teaching and our training, both as students and then through our clinical practice and post-qualification. And that's embedded with completion of really holistic multi-system assessments. As part of that, we care for patients who have got both chronic and acute illnesses and conditions, and we're embedded across the NHS services in primary, secondary and tertiary care. Most of our training, as a caveat, is really linked, more geared up towards adults, and I'm coming at this very cognizant of the fact that paediatric and young people are not mini adults. And that's one of the challenges that certainly my team face, is that we are generally adult clinicians and adult therapists, and in a world that we need to be cognizant that the children and young people have got quite different needs potentially to the adults. Next slide, please. So for people who don't know, so the oxygen service at the Royal Brompton has gone through quite a metamorphosis over the last sort of 18 months to 2 years. Historically, it was staffed by a band 5 technician who would prescribe oxygen for both adults and paediatrics on the recommendation of the medics who were at the bedside and the primary caregivers for individual patients. The IHORM and the consent forms were all completed either remotely or at the bedside. And again, this was both adults and paediatrics. So over the last 18 months, we've tried to uplift our staffing in line with the BTS guidelines. So we've got band 7 physiotherapist again from an adult background, and myself overseeing the oxygen service across the Brompton. We have moved away from prescribing ambulatory oxygen within the hospital and making sure that we're sort of farming that out, pushing that out to the more appropriate environments in the community. And we're also trying to reduce the number of LTOP prescriptions on discharge in line with the BTS guidelines and across both adults and paediatrics. So the paediatric service is still covered by adult therapy services. The nursing staff and medical teams are absolutely fantastic at getting the IHORMs and the consent forms completed at the point of referral to us. But I think the thing that's often lacking is our oxygen service being embedded within the MDT around the decision-making processes around some of the cases, and the device and flow rate is generally prescribed on the recommendation of the primary caregivers, which is appropriate, but there's a bit of a disconnect from a sort of safety and a governance perspective then around an adult therapist sitting in a very adult governance structure, because we've recently merged with Guy's and St Thomas's, so all the children's services are now under the Evelina, and my team is under an adult therapies directorate. So from a governance and safety perspective, we're sitting in two different strands, and so we just had some concerns about managing that. Next slide, please. So just to really put it in context, so our oxygen caseload across the board is around sort of 200 plus referrals a year. This is for paediatrics. So for 2020 to date, we've had 19 inpatient referrals, which are generally for new setups of LTOT, and a few are amendments for discharge. Something that we do not audit, but I would like to do next year is to look at the number of urgent orders, so the 4-hour orders that are going out. Anecdotally, that does feel that is quite a high proportion, and there's usually something about 3 o'clock on a Friday that the referrals start to come through with urgent discharges. And then we also have a mailbox and a telephone line that anybody can, that families and the MDT can also get in touch with. So about 15 inquiries across the year from either families, and often this is around prescriptions for holiday, for going abroad, or for changes in portable equipment as children get older and they outgrow their buggies and then they need slightly different equipment for getting out. Both families and MDT inquiries around school supply and amendments to the HOOF to reflect that. And actually, this year we haven't had any HOOF escalations, which is refreshing compared to the adult population where we have quite a few. So certainly in the paediatric arena, then we don't have any HOOF escalations coming back to us. Oxygen can be quite time consuming from a therapy perspective. We've got on average about 40 minutes of contact time per referral, but that can go up to about an hour and a half, so over 100 minutes for some patients for more complex cases. Next slide, please. So as I've alluded to already, and Tendai and Moni have sort of discussed some of the points already, is looking at the challenges for the prescriber. We feel often that we're several steps away from the assessment process, and being more embedded in that process would be better for both the caregivers and also potentially for the children. And we've now, as I've alluded to, got different governance teams. So with the restructure and the merger, the Evelina has got their one governance structure, and then the adult therapy team has got another governance structure. So managing the risks associated with prescribing oxygen potentially for a child that we've not assessed and we've not met ourselves feels a little bit uncomfortable. So that's some of the work that we're going to try and pick up moving into the new year. Very cognizant, again, following on from the issues that we've just discussed around smoking, in that risk assessments carried out by the phone or at the bedside, in not every case, patients are not having home visits. So actually looking at the risks around fire, the risks around falls for codependents also living in the property, and also about the storage of oxygen equipment being safely maintained within the property. Nobody within my team has sight of those assessments. So the risk, if there was any incidents, then falls with us. We've got a very wide geographical catchment area for both our adult and paediatric patients, being a tertiary centre in London. We will deal with every oxygen, so all 3 of the oxygen company providers across the UK, and a very, very wide catchment area. So linking in, again, very time consuming, and one of the things that I'm really keen to get from this network is to build those networks so we can make sure that we've got a really effective handover process between our community services and linking things up. And as I've said as well, we feel like we've got quite a high proportion of last minute and urgent same day orders going out, particularly on a Friday. So certainly an area for improvement is how we can embed that process better into discharge planning and utilising the advice from the web that we've discussed already. Next slide, please. I think this is my last one. Yeah, so what we'd like to do next is looking at an audit, looking at our caseload, looking at the frequency of urgent and 4-hour orders to see if we can control that and improve that. And also get some service user feedback. So actually liaising in with our MDT colleagues. I've already started having conversations with the nursing leads at the Evelina to see about joining the services up with the view to actually handing over oxygen into the paediatric team fully, because I don't really feel that it fits very well within the adult team. And then improving our links with it, both in-house and community MDT, so we can make sure that the risk assessments are happening before oxygen is being installed into the properties, that those risk assessments are carried out within the home. And that's a whistle-stop tour from me. Thank you.
Thank you very much, Gemma. That was really useful. I'm just picking up, I think there was some comments. Yeah, so Moni has just suggested if you're happy to meet with her outside this meeting to see how the air liquid reports can help identify the urgent requests linked to these cases. So there's some reports that she can be able to help you with.
Thanks.
And then there is a question as well. Jem, okay, somebody's asking, Gemma, can we ask about the transition between children to adult services? Are you on the call? Let me see who wants to ask that question. What's the question specific, Safina?
Hi, sorry, it's Paula here from the Harrow Children's Community Nurses. I'm sitting with Safina and Regina. Yeah, the question was, so we have a couple of children on the caseload that are coming up 17, 18, that NIV and using oxygen at home, one young man on a ventilator at home. And I'm just wondering about the transition process, who we should be contacting at the Brompton. Is that you, Gemma, to discuss taking forward, etc.? Those transitions. And I see Caroline's just written to say there's a PPLOG document for transition, which I wasn't aware of. So we will have a look at that as a team as well.
Right. Yeah, so certainly at the Brompton, if it's a ventilated patient, there's kind of 2 agencies involved. So we've got the respiratory support team who would then be overseeing their care from a ventilatory perspective in the community. And then the oxygen team would be looking after the hoof unless there's, or for any upgrades, unless the community services are able to take that forward. We do work with a lot of community services, certainly in the adult arena, where there aren't sufficient services for them to take on some of the prescriptions from the Brompton, and historically the quality of some of the Brompton prescriptions hasn't been brilliant, that people haven't been willing to take them on as well, which hopefully, as we've started to put a bit of a quality control at the door, hopefully that will change. But very happy to be emailed. We've got a generic oxygen email.
Great. So could you share your generic oxygen email maybe in the chat or something like that? That'd be helpful at the end, maybe shared with the professionals. That would be really helpful. Thank you.
No problems.
Thank you, Gemma.
Thank you.
I've got another hand. I'm just trying to find the hand. Oh, Caroline.
Hi, it's Caroline Locke from Air Liquide in London. I guess one of the things about transition is some of the rare diseases and genetic components of pediatrics. It's very difficult sometimes to, box them into a specific home oxygen services because they may not have the services that they've been accustomed to in pediatric services, and when they go to adult services, it's all quite difficult. So I think early referrals is a very important aspect, and I think that's what the document on transition document in PLOG refers to and alludes to. I just wanted to say that, that's all.
Thanks, Caroline.
Yeah, thank you. Yeah, thank you, Caroline. Yeah, thank you very much, Gemma. That was really useful. And I think it's probably a question back to you, Gemma, because you played a pivotal role, as an allied health profession, supporting that transition from a band 5 technician ordering the oxygen, and you took up and your team to do that. So in the future, is there a key role that allied health professions can play within children and young people in home oxygen? What would you say? Because as we're talking about service specification and how teams and the support, what would be your recommendation really?
A good question. I think certainly for the older children potentially coming into that transition phase, because as I said right at the start, there seems to be less AHPs doing oxygen in paediatrics at the minute. There could well be roles within ACPs and the way those are going in the future, more for paediatrics for AHPs, but certainly where the physios and the AHPs are already established from an oxygen perspective in potentially the older children. And there's often AHPs embedded in ventilatory services as well. So whether there's a link and a niche for physios specifically to work in those environments and to pick up doing some of the oxygen prescribing and monitoring in that situation would be useful.
Okay. Yeah, thank you. I think it's just so that we can highlight, because I think part of the service specification, we say the health profession, because sometimes people can interpret that we say the nurse, but actually if there is a role that even allied profession can support that and be able, so it could be a nurse, it could be allied health profession, it could be, so somebody who has got that healthcare knowledge and understanding about home oxygen and children and young people could be pivotal to supporting that. So, okay, thank you. Thank you very much, Gemma. Caroline, I use your hand up, or is it a legacy hand? I think it's a legacy hand.
Sorry, it's a legacy hand. I couldn't hit the button quick enough, sorry.
Okay. So our next speaker is Mira. Just trying to bring the slides back up.
Thank you. So I'm sharing the office with a couple of nurses, so they know they're trying to be quiet as possible, but apologies if there is a little bit of a noise.
That's fine. I'll hand over to you. So Mira is going to be talking to us about smoking, vaping, and oxygen requirements.
Hello. So yes, I'm Mira Oshinibi. I'm the specialist nurse, respiratory specialist nurse in King's College Hospital, and I also do smoking cessation in our service as well. Yes, I would like to talk about smoking, vaping, and what it means with the oxygen requirement. Okay, so next slide, please. So Tendai kind of said to me to kind of really go into the kind of the details about what is smoking, tobacco, vaping, just before we kind of understand why it is important, obviously, for all of us to understand when anybody is on oxygen and why, ticking the box, in the kind of guidelines and PPLOG for about smoking cessations. And, it's really important to kind of go into the basics. So what are the respiratory effects of, specifically tobacco smoking? So the inhalation of the cigarettes on its own triggers the marked cellular influx. So we're talking about the oxidative injury on the lungs on its own. So it's with the tobacco, it's the combustions of the cigarette, of the tobacco, that it's triggering. Smoke related, we have lung disease, asthma, production of phlegm, for example, cystic fibrosis. So, these are a couple of effects on people who actually smoke. you know, and sometimes even with a secondhand smoke exposure, they also can have triggering of an asthma attack, also production of phlegm in cystic fibrosis, and they don't have to smoke themselves. The smoke-derived oxidants are the major factor in inflammatory reaction with the cigarette and smoke. Remember, the tobacco has about 4,000 toxins that are really not beneficial for anybody. So when we're talking about oxidants, there are quite a lot, not just, you know, few. They facilitate trafficking of neutrophils and macrophages, inflammatory cells. As we all know, neutrophils and macrophages are, you know, something that everybody has. And when you have a chest infection or anything, you know, they're important parts of the defense, the immune system defense. But, you know, when somebody smokes or you're exposed to secondhand exposure, this is constant, this is chronic. This is not only a natural defense of the immune system, this is a chronic trafficking of neutrophils and macrophages that the body is then overloaded with the macrophages and cannot get rid of it. And that becomes chronic and develops, you know, obviously carcinogens and COPD and all other aspects. And it causes of COPD, as we know, obstructive sleep apnea, and also lung cancer. So many people kind of, you know, when I'm talking to smoking adolescents who smoke or even vape, they are not thinking of COPD because they think it's a disease of an 80-year-old, and they believe that you know, they probably developed it when they were old, but they don't understand the chronic impact of you can get a COPD even when you're 35, you know. And we do have patients with obstructive sleep apnea, and these are the patients who will have prescriptions of oxygen and also non-invasive ventilation. Next slide, please. So with the tobacco specifically, what is the most thing that we kind of look at, and what is the most dangerous is the carbon monoxide. What is a carbon monoxide? It's a product of combustions in the cigarettes and cigars, and also motor vehicle exhaust. It's really rapidly absorbed in the blood system, in the bloodstream. The level of the CO in part per million corresponds with the percentage of the blood cells carrying the CO instead of oxygen. So when I do the carbon monoxide in my service for the smokers, when I say your CO today is 15, that means 15% you could have an oxygen rather than the CO. So, you know, I'm quite keen to not just to give them number, but to kind of explain what it really means. The carbon monoxide has a half-life. It stays in the body for 5 to 6 hours. So sometimes, you know, if somebody smokes only 5 or 6 cigarettes per day and nothing through the night, the carbon monoxide might be a bit low in the morning, you know, especially if they started smoking maybe 2 to 3 years. So it doesn't accumulate enough, but it doesn't mean that it's okay to smoke even 6 cigarettes, especially if it's an adolescent. So that's something that I have to sometimes explain to smokers. The carbon dioxide returns to normal after 24 to 48 hours of not smoking. And this is important because many smokers do not know this. So they might believe that they've been smoking for 20 years, they have a carbon monoxide check with someone, and they go like, well, you know, it's been there all the time, and probably it's going to be very difficult for me to get rid of it. But actually, some of the very heavy smokers who start vaping, for example, the carbon monoxide is completely normal after 2 days, you know, or even if they start decreasing smoking, the CO started decreasing. So that's quite important message to smokers as well. Next slide, please. Also very important, secondhand smoke. This is the major you know, reason why we develop smoking cessations in our service, because I'm a pediatric nurse. Why would I be doing a smoking cessations for adults? You know, they are not my patients. Yes, I care about everyone, but what is important in our service is that we need to stop secondhand smoke exposure for our children. There is no longer kind of a question about, you know, do you smoke but outside? You know, that question should not be even asked. Where do you smoke? It's a smoke. You're smoking anywhere you smoke. The carbon monoxide will be on you no matter how you smoke. There is no way you're changing your clothes every 5-10 minutes, you know, or every time you smoke. So this is a really, really important kind of service to be given to, you know, to be held with in any kind of clinic, really. And why that is because secondhand smoke exposure already increases the risk of respiratory tract infection. The children don't have to smoke. There can be a sudden unexpected death as well, for example, with asthma, especially with adolescents who have asthma already. For example, we have typical asthma children who are adolescents. They, on their own already, they are not, they are not taking their inhalers as they should, and they smoke. And the asthma could be fine today, but there is more danger of actually dying much faster than any other children or an adolescent because they smoke, and they are not linking this together at all. Children are more vulnerable for secondhand smoke exposure because they breathe in more rapidly, they have a higher relative ventilation rate than adults, and also they do not have a choice to leave. I can be in a restaurant outside, I can be sitting somewhere and I can see people smoking. I have a choice to leave. I have a choice to, if I was renting a house, I have a choice to say, are there any smokers in there? Children don't have a choice. They can't go anywhere else. And that is that, they become really vulnerable. Next slide, please. So let's talk about vaping, which I don't think we were talking enough before. I know the PPLOG guidelines where we have to, when we're doing the risk assessment has a vape, but not many people understand the vaping. So yes, it's 95% less dangerous than smoking tobacco, and I'm really up to it for smokers who smoke a lot. And if I can see a smoker whose CO is 25 one day, but they vape the next week and it's completely normal and they tell me they feel good, I can't tell them this is bad for you. However, I always tell them the vaping is not a changing of one habit to another. We don't know enough how is it actually chronically, what is it do to the lungs as well. So it's really, really important that we're kind of giving the message. But when we're talking about oxygen, we need to understand that this is vaping. The electronic cigarettes have a power source, and it has a USB power port, and it's they're using separate battery chargers. This is on its own. It has a risk of ignition while patient is on the oxygen therapy. So for example, adolescents when they vape, and they do vape, and then it's a lot. And I'm just doing at the moment vaping dangers in adolescents in secondary schools, because there is a very little information about how dangerous it is, especially nicotine and anything else. They think it's very cute, very small, what can happen. So they're also, even if it doesn't have a separate battery charger, they don't understand how dangerous it is, because it looks very nice and small, and the whole message about being less dangerous than tobacco is really misleading. So, this is something that we need to kind of tell them, especially if they're on oxygen, why that is. Why is it not beneficial to them either? Because with, as we know, with adolescents, the cells are not developed properly, they are still growing, and the actual vaping is more dangerous to them than adults. Also, we have to understand it's not just nicotine in the vape, there is also flavoring, propylene glycol, glycerin, acrolein. All of these are inducing multiple allergic symptoms in children, especially. And that's why they might actually end up in A&E much faster than other children, especially if they need oxygen as well. Next slide, please. So what is the prescriber's involvement, and why would the prescriber need to be involved in it? So I believe, no matter if it's in the PPLOG guidelines or not, in my opinion, it's every clinician's responsibility. It is not about, well, I'm not a smoking cessation specialist. I wasn't asked to do, to kind of go through the guidelines or go through some kind of a teaching. I think every clinician's responsibility to ask if the patient is smoking or not, and offer at least very brief advice. And we can kind of independently, and then I kind of talk about in the next slide how we can actually all of us do that without anybody's kind of giving that on a plate. What I believe in, and it is on the guidelines from BTS, is every contact counts. So, for example, if I ask about the smoking and the person is not ready, they are not ready. That is completely fine, especially in our service when we have adult smokers who will say, well, I don't give them an option. I don't say, would you mind me talking to you? I will just tell them, this is one of the part of the service that we do. And I'm asking you, I'm going to give you a brief consultation about smoking. When they say, absolutely not, I'm not happy to do this, then it's fine. But then I will tell them, I'm going to ask you again next time, or somebody else is going to ask you the next time. So if they are not ready for me, they might be ready for the oxygen prescriber next time. we have to remember that everybody who smokes, they don't enjoy it after 40, 20 years. Maybe adolescents do, but they are reluctant, they are guilty already. They might be, can look offended, but they are guilty that they're smoking and they just don't want to say it. So for example, one day they might be in a mood that, look, I don't want to talk about it, but the next day they do. So every contact counts. And also there is something in smoking cessation kind of world is teachable moment. So basically, as I mentioned, not everybody is motivated today. They might be motivated tomorrow. Whatever it means, people going through all sorts of different stages in life. For example, today they might be more oppressed or more, they might be going through something that they just, obviously today is not the day that I want to stop smoking, but tomorrow or next week might be the day. So we have to really look for the teachable moment. And the teachable moment also is, you have been prescribed an oxygen. And why? Is it something that, okay, has been chronic? Of course, you have asthma. This is not because you're smoking, but is the smoking going to make the oxygen to go away, or could the oxygen actually be, the level of oxygen that you are prescribed, could it be higher because you're smoking? So this is one of the teachable moments, is that when we are prescribing oxygen, when we're seeing them with the clinicians, these are the time, if we don't ask them, they will think, well, I've seen 50 clinicians and nobody asked me this, so it must be okay. So these are one of the teachable moments when we do that. Staff, in my belief, can be trained for basic information of very brief advice, and it's very quick, and it is not so complex, as people might think, and it's quite easy to kind of be trained on. And I think it would be really good if some services can develop something like Stop Smoking Champion, someone who is more interested than any others, who might be kind of like a lead of smoking cessation. Next slide, please. So as we can see in PPLOG discharge bundle, we already have the questions about do you smoke, because obviously risk assessment. So this is great, and this is the time where we can give them a very brief advice, for example, when we go for the training. Next slide, please. Is there any? Oh yeah, brilliant. And I think if you click it again, sorry, I thought that I will have, yeah. So basically on these competencies is the first one where we're talking about, smoking and electronic cigarettes. And this is the time where also not just saying yes or no, this is the time when we kind of explain a little bit more about the smoking and the harm and the vape, and I know that I've been doing it for a while, and I'm a quite fast talker, and then you think, well, I'm not going to have the time to kind of go through this very brief advice. But actually, when you go through it a couple of times, you will find that you remind me about 20 sentences just to kind of really summarize it. And at least that's something. We are not saying that they're going to stop smoking the next day you talk to them, but it's about the moment, and it's about how many times they're going to be talked about this, and it's accumulated, and that's going to trigger the motivation. Because motivation is not that they wake up in the morning to go, wow, sunny day today is the time when I stop smoking. It's actually the habit of other people reminding them, and that is the actual motivation. Next slide, please. So these are the training. So I've done the NCSCT training, Stop Smoking Cessation. The website is brilliant because they update it quite a lot. They do smoking cessation for tobacco, for vaping as well. Also, there is more kind of updated information about smoking, and so it's not just the training, but they update information for people when they want to know about something that is going on. Also, I found really useful, on the right side, you have the website, obviously, from NICE, the guidelines for preventing uptake and promoting quitting and treating dependence is really, really interesting to read as well. So that's why I just put it in there. Next slide, please. So just really briefly, so it's smoking cessation in Kingston. So this is what we do. We do it for obviously parents in our Thursday clinic, where we see at least 38 patients, and obviously they come with parents, sometimes with both. We give them, most of the clinicians, sometimes they forget, they ask, do you smoke? It's the same as, are you allergic to this and that? So basically, do you smoke is one of the questions that they ask in, about the about the diagnosis or clinical kind of aspect of the disease. Meanwhile, sometimes I get a referral from cystic fibrosis and asthma as well. We have a new service with dysfunctional breathing when we have a brilliant physiotherapist who sees the patients herself in her own clinic, and she always gives me quite lots of, I have quite a lot of referrals from her actually. Sometimes maybe they seem to kind of open up to her more than the doctor, I don't know, but so I get referrals also from inpatients as well. So I'm asking about smoking status, how they were smoking, history, what is something that they have to deal with, did they try anything? So I give them all the information that they can kind of gather from me. I don't give them any nicotine replacement therapy, but I give them advice based on, the guidelines that is actually now. Because sometimes they just kind of don't have this information. They only have something that Daily Mail told them, or maybe somebody, auntie or uncle told them. So this is something that is, based on actual guidelines or, the kind of newest research. Then I give them a plan to, to do what they can do, either reduce or vape, or I kind of give them what they can do, what they can use in terms of nicotine replacement therapy. They go, sometimes I see them again and review them. I do carbon monoxide monitoring as well. And, and, sometimes I do a telephone consultation as well. Next slide, please. So this is just a really kind of one case study in terms of when we're talking about kind of referral within our service. So we had a 17-year-old female respiratory patient who came to a non-invasive ventilation clinic. She also sees the endocrine because she's got excess of BMI. She had a bariatric surgery. She has she's insulin resistant. She snores. She has obstructive sleep apnea. And they need to initiate of NIV. So obviously one of the CNS nurses were talking to her, and it obviously clicked to her that actually, she asked about, do you smoke? And, that kind of initiated to refer her to me. So, it's not that this child is not on oxygen yet, but we had to initiate a non-invasive ventilation. Why? Because she has any other, she has different issues, but one of them also is that she needed non-invasive ventilation. So, this is not really great for her because she can actually develop COPD much faster and needing more oxygen than other children. So this is just one of the samples. Next slide, please. So the learning outcomes really is smoking has major health effect on children's lungs. They can further deteriorate if they have an oxygen or they have an NIV. They also, when they're exposed to secondhand smoke exposure, vaping and oxygen obviously hazards in a household. Ask the questions, is every prescriber responsibility? And, the PPLOG Band competence skills risk management, we already have it in there. And the smoking cessation and information training is online. And I think it's we can all do it. I don't think it's a kind of rocket science that we kind of think that we can all do it. Next slide, please. The last one. So this is just the references where I think I leave it in there, and people can actually kind of look at them. It's really good to kind of look at it about smoking cessation, tobacco, vaping, especially from, for example, even in motivational interviewing, which I'm using in our service, and also some publications from myself. We've written a paper in Lancet about passive tobacco smoking children and young people during COVID-19 pandemic, and we published also in European Journal of Pediatrics in April about our smoking cessation service. Thank you, that's all.
Thank you very much, Mira. That was really, useful and informative. Just going to pick up, because I'm mindful of time, I'm just going to pick up one or two questions. Okay, somebody's already been answered because somebody was asking about training and a link was put in the chat, and we'll be sharing the slides as well. So there's a link in there, and there's a question from Karen. Is there any evidence that secondhand smoke can lead to COPD in the young people?
Well, you can't have an evidence from, they would have to have a research from when the child is 4 or 5 and has asthma and follow them until they're 50 or 60, and which we don't. We already know that why the COPD, becomes a COPD, because of the carbon monoxide, because of the smoke. We already know the secondhand smoke exposure already give the inflammatory kind of aspect to the child or to the body. Even with adults, we're not talking about that it's harmful for children. Secondhand smoke exposure is harmful for everyone, but we are saying that the children are more exposed because of the higher rate of breathing and all sorts of things. So you don't really need a huge research in terms of it's obviously, I don't think we're thinking of the children who are exposed heavily, for example, from both parents of the smoking. And let's say they are 17 and they start smoking. And let's say they might not smoke as much as the parents. And then let's say then in adulthood, their activities or their lifestyle might not be the greatest. Then yes, they are more exposed to COPD than any other children. If they are not exposed to secondhand smoke exposure in their childhood, they might be smoking at the 25. They might be less exposed to COPD, but these children have a double whammy. They are exposed when they're children, and when they're adults, then they have a not the greatest lifestyle. So yes, I think there are more without the research. I think they are more exposed to COPD.
Thank you very much. So there's some comments and questions in the chat, but I won't pick it up. You can pick it up in the chat. There is something to look forward to. It's only because of challenges of capacity, but we actually did a survey with Mirror last year, isn't it? And there was 2 parts of it. One was actually capturing the experience of the adolescents around smoking, and the other one was professionals as well feedback. So we are hoping to get those, one, published, and second as well, guidance as well being produced. So please do as well read those articles that Mira has highlighted, that she's done her work. She's been working closely with one of her consultant in Kings around this. So this is quite useful information. So thank you again, Mira, for that presentation. So we'll move on. I was meant to give you a quick break. If you don't mind, I will give you 3 minutes to quickly stretch your legs and quickly rush, and if you need to use facilities or anything. So it's 16, so 78, so 19 past, please. Could you be back? And then Emily will be ready to do her presentation. So I'll give you just 3 minutes to stretch yourself. So see you at 19 past.
Hi, Tende.
Mm.
I'm going to share my screen if that's okay, just because I've got quite a few slides. Is that all right?
Wonderful.
Brilliant.
Let's check. So if anyone is back, just put in the chat box if you're back. Yeah, thank you. Thank you. Yeah. Wonderful.
Perfect.
Thank
Cool. I'll
you.
make a start then.
Yeah, you start.
Hi, so my
Okay.
name's Emily. I'm one of the respiratory nurses at King's College Hospital in NIV, LTV and sleep. So today I'm going to be going through a case review on a patient who was discharged home on oxygen via a home portable ventilator. So we'll just go through the case study to begin with. So for the purpose of this case study, the patient has been anonymised to child A. So this particular baby was an 11-month-old with a clinical diagnosis of chronic lung disease of the prematurity, was one of a twin born at 27 plus 5 weeks gestation. This baby was the donor twin in twin-to-twin transfusion syndrome, had necrotizing enterocolitis, had gastroesophageal reflux disease. So this baby had been cared for on the neonatal intensive care unit since birth. We're at a point that he was stabilised and ready to go home. So the respiratory team, which is us nurses and the consultants, all worked together very closely with our discharge coordinator, so one of the well child nurses, to prepare for his discharge. And because of due to the severity of his chronic lung disease, this baby required nocturnal ventilation, so CPAP, 8 centimetres of water overnight with oxygen on top of that. And then in the daytime required a trickle of oxygen, nasal cannula oxygen. So already there's kind of within that 2 different oxygen prescriptions, one for the daytime, one for the nighttime. Sorry, my sound went all funny. The oxygen, so it was prescribed via the HOOFs, which is a home oxygen order form on the Air Liquide portal. So this child in hospital, so he was on the portable ventilator, which was an Astral 150. So he was set up in hospital and he needed 6 litre per minute of oxygen, which equated to 45%. So we, on the HOOF, we prescribed 6 litres per minute because this showed good gas exchange. Based on the sleep studies, it was the appropriate amount. And then we prescribed 0.1 litre per minute of oxygen via nasal cannula in the daytime. So the 6 litres per minute in hospital with the pressurized walled oxygen equated to 45% on the oxygen integrated sensor on the Astral machine. When the baby went home, the same flow rate of 6 litres per minute via an oxygen concentrator equated to 31% FiO2. So there was a discrepancy of about 14%, which obviously was quite concerning for everyone involved. So it is so the child, so it's essential that the child achieve the 45% because of all the studies that we performed in hospital. We knew that this was the correct amount. He was on a SAT monitor and actually his oxygen saturations were stable the whole time, because obviously if that wasn't the case, he'd have to come back into hospital. But it was a real difficulty trying to achieve this 45%. So with contact from Air Liquide, so Caroline Locke, the nurse advisor from Air Liquide, and the technicians, we had to install 2 intensity static concentrators. So it's 2 of the big ones. There's a photo on the next slide, and it had to deliver 5 litres per minute, which is the maximum through each one, and it achieved 10 litres per minute in total. This then gave us 45% FiO2. As you can imagine, this caused a lot of stress for everyone involved. But the baby was safe, and ultimately that's you know, the most important thing. So it was a real learning curve, this, and there were so many questions that came about after it as to, you know, what do people do who are prescribing sort of like big amounts of oxygen via portable ventilator? Is there a maximum? Kind of what's the safest practice? Because at the minute there's not many guidelines out there. So sent a survey out to 14 different hospitals. So you can see there's the tertiary centres in London, and then also other centres around the UK. So thank you to everyone who participated. And going through the results, so this is just an interesting one to start with. So what portable ventilator do you use to set up NIV and LTV? So predominantly it's ResMed ventilators, so the Stella kind of comes in first place, and the Astral. The Nippy Juniors are also quite popular, the Trilogies. So there's lots of different ventilators there. And the reason it's important to find this out is some ventilators have an integrated FiO2 sensor, and that literally means a percentage that comes up on the screen. So whatever 3 litre per minute is, it will give you the percentage of that. So not all ventilators have it. The most up-to-date ones do. For the purpose of this case study, it was the Astral 150. So nearly half of nearly half of the ventilators have this sensor. So when reading the supplemental oxygen being delivered, do you read the FiO2 reading on the ventilator or the litre per minute via the oxygen delivery device? So some people read both, other people quite strictly it's litre per minute. We'll come on to this a bit more later, actually, why it is important. So this was really interesting. So have you noticed any issues with compatibility between the oxygen concentrator and the portable ventilator? So some people, so 60%, so majority said no. There's not to say that there haven't been discrepancies, but nothing they're kind of aware of. 15% of people said yes. And then there's other responses which are very interesting, such as, so a parent noticed that a child didn't seem to be getting as much oxygen via the concentrator when attached to the ventilator than when the ventilator was connected to the cylinder. So the cylinder, pressurized cylinder, works in the same way as your hospital walled oxygen. It has that higher PSI. The oxygen provider checked the concentrator and they were advised it was fully working. Only on a few occasions, one when a child had a high oxygen requirement via NIV, the community team noticed that the concentrator didn't comparably provide the required oxygen. Interestingly, this patient was also on an Astral, and the percentage of oxygen was prescribed rather than the litre per minute. So on high flow oxygen, 8 to 10 litre per minute, the person ended up using 2 concentrators back to back to give 5 litres per minute on both. And actually that's the same as what we had to do here at King's. So do you send the patient home to test the oxygen compatibility with the portable ventilator prior to discharge? So generally speaking, for NIV patients, you don't need to. That's not sort of standard practice at the moment. It's more for your LTV patients, so ventilation via a tracheostomy. So 50% of people didn't. And then there are some people in some cases where they have, but not necessarily to specifically test the oxygen compatibility. There's a really nice response. So we have now secured a concentrator for the training room so that we can try the flow on this. And actually, this is amazing. If we could all do this, that would be great, because I know that you can loan a concentrator from Air Liquide. I'm not sure about the other companies, but I know it comes with costs and funding and space and all those kind of things. But if we could, ideally, we would do the same at King's. Some centres, they're not the ones sort of leading the discharge. They come from the tertiary centres who take responsibility for that. Again, you know, it's not everyone's responsibility to prescribe the oxygen or supply the equipment. Yeah, and in some complex cases, dependent on NIV, home leave is required. And then there's a few oxygen providers. So predominantly people use Air Liquide, but there's also Dolby and Bock. So how do you find the oxygen prescribing process? So some people found this okay. A small percentage, 10%, found this easy, but the rest, it's kind of confusing, slightly complicated, very complicated. Some people have found, so here it's Bayswater is easy, Bock is difficult. So there's lots of different responses on that one. Do you feel there is enough resources to assist with prescribing oxygen when it is to be used with NIV? So some people say yes, but actually most people find that there isn't enough resources out there. Advice on compatibility would be helpful. It would be useful to have additional guidance available for teams. And I agree with this one. There's lots of information support the oxygen prescribing process on the PPLOG. However, actually, when it comes to prescribing of NIV, there isn't at the moment, and I think this is what we're trying to work on to make it a little bit more of a seamless process with discharge, and also, you know, ultimately a safe one. Do you tend to complete the sleep study once a child has been discharged? And the reason I asked this question was, so this particular child, they had a SATs monitor, but we were very concerned that actually they could be desaturating without us knowing it, because not all DSATs will pick up on a SATs monitor. Hence why we felt that we would do kind of an emergency sleep study with the oximeter to measure the oxygen saturations. And the reason this one is interesting is because some centres, at the minute there's no guidance for this, there's no right or wrong answer, but some places it's within a year, up to a year, 6 months, 3 months. So it's kind of thought that actually if a child was desaturating, and I know there'll be other signs, but if this wasn't picked up, it could be quite a long time before the oxygen can be altered. So do you wean oxygen using the child's oxygen saturations on the monitor, or by conducting a sleep study? So majority of people use a sleep study. Some people do a bit of both, which is obviously also important, going by the clinical picture and the vital signs as well. Have any parents reported that their child desaturated when using their ventilator shortly after discharge, and have you had to increase the oxygen based on this? So most people said no, but actually 25% of 20 responses, so it was 14 hospitals, but within that 20 responses in total, which is quite a lot really. It's about five people have found that there have been issues with a child desaturating at home. And then this one, it's a very colourful diagram here because there's lots of different answers. And this is the one that we want to pick apart a little bit more. So what is the maximum amount of oxygen that you are prescribed to be used with a portable ventilator for the duration of the night when delivered at home? This is not emergency oxygen. This is simply the oxygen going throughout the night. So the one that you're not really changing. It's a set limit. So this, as you can see, ranges from, well, every single thing there. So from 3, 4, 5, 8, 10, 15 litres per minute. Sometimes, so usually, if someone said usually it's less than 4 litres per minute, but some cardiac children have gone home with higher requirements. Palliative care is a whole nother kind of scenario. Generally, people do deliver much more. Someone has said that they try to use a concentrator, which sounds like it's the intensity one, which can deliver up to 5, or the V5, sorry. But if you needed to go more in an emergency situation, it would be via a static cylinder, because you can deliver that through that pressurized oxygen. Depends on the child, depends on the escalation. So there's a real mix of answers here, and it's unclear as to what is the right or wrong thing to do. And I think this kind of thing is going to have to be a joint decision, because at the minute we're just not sure. Skip over that. So the 4 themes that came out of this scenario, which I think we can learn from and move forward. So one is the education and training element, so the awareness of the different oxygen delivery devices and how to prescribe. Then it's a safe and achievable oxygen delivery, which again, we're not quite sure on, but what actually should we be doing at home? What's the maximum amount? The prescribing process, so how to actually do this safely. And when you have difficult scenarios, which as more and more babies now with chronic lung disease being discharged home on portable ventilators overnight and nasal cannula in the daytime, they are a lot more complex. So it's just having that support with the prescribing. And then compatibility testing. So the education and training is the first theme. So differences in the PSIs, the pressurized flare index between hospital walled oxygen and oxygen via a home static concentrator. So the walled oxygen and the oxygen cylinders, they have that pressurized oxygen to give you that 100% purity, whereas a concentrator is using the air from the atmosphere to pull it into the machine, to spin it around, take out the nitrogen, to give you that as pure oxygen as you can get. But actually the purity ranges from about 86% to 96%. After, Caroline, you can correct me if I'm wrong, but around that, so it isn't 100% purity. And then again, with that, the differences in the functionality of a hospital ventilator compared to a home ventilator, they both work very differently again. And then to have an understanding of the different types of oxygen delivery devices and when to use each one. And I know there's lots of resources on the PPLOG for this, but just in terms of specifically with NIV. So the safe and achievable oxygen deliveries, this is where we kind of need help from the wider group. What is considered a safe amount of oxygen at home? How is this oxygen being delivered? Yeah, lots of questions with that one. The prescribing process, so Caroline Locke, one of the nurse advisors at Air Liquide, has created a step-by-step guide with scenarios of paediatric patients who will be going home with oxygen via NIV. So this won't be on the live portal just because it's a universal portal that everyone uses, so it won't be applicable to everyone, people that aren't on NIV basically. But there will be a pack going out on the PPLOG, and it will tell you, kind of give you little prompts about how to do certain things and how to make it safe basically. And things like with a static concentrator, you always need your backup cylinders, so telling you, you know, how many backup cylinders you need depending on the flow rate that's prescribed, all those kind of things. Compatibility testing, so this will be the responsibility of the discharging hospital, which is probably usually the tertiary centres. So it's home leave. Patient needs to be tested on the equipment at home, and just to expand on this, they should be put on the portable ventilator with the desired amount of oxygen, with the SATs being measured on the monitor. So it won't work because of resistance and leak and everything like that. You have to actually put the child on the monitor. So it's not a case of, oh, we'll just take the ventilator home and plug it in, because it's not going to give you an accurate reading. And then any discrepancies or concerns should be flagged. And then there's a safety checklist, which is an amazing checklist. It's already been devised by the PPLOG, which is great. We use this, and I know lots of centres do, for children going home on nasal cannula or oxygen via a face mask or a trachea mask, or whatever it may be. This is amazing, and you can't go wrong if you follow every step. So we thought to kind of expand on this, it'd be really helpful to have one specifically for prescribing oxygen with NIV. And when I say NIV, I mean LTV as well. So this is just a kind of a provisional one that I have devised with the help of Emily, who's also used to be part of the PPLOG. And it's there's 7 steps to it, but it's just kind of highlighting the really key points. So I'm just going to read them out quickly. So patient weaned to an appropriate amount of oxygen, which is achievable and safe to deliver in the home setting. Patient has been sent on home leave and equipment trialled on the current settings of CPAP BiPAP with the current oxygen requirements. Equipment must be trialled on the patient. Patient's O2 SATs must be monitored. If this is not possible, complete a home sleep study within the first few nights after discharge. And the reason this may not be possible is issues that we've had is lots of babies are being discharged from NICU now, and obviously with the infection control policy, they're not always able to come back onto the unit. So we're trying to find sort of loopholes around it. But, you know, if you can't do that, it's not always possible. So a sleep study would be required. Have any troubleshooting issues been resolved prior to discharge? This could include concentrator unable to deliver the desired amount of oxygen. The child requires a different oxygen flow rate via the concentrator, so you may need to increase it like we had to. The child is desaturating. Are parents satisfied with their child, that their child is comfortable on the ventilator at home during home trial, is receiving the desired pressure and oxygen requirements, and they are saturating at their baseline? So just really important to involve parents with this. They know their child more than anyone, and they actually, from what it would seem, as parents are the ones that are picking up on these discrepancies, probably more so than we are. Has the home oxygen advisor, so this could be, for example, someone like Caroline Locke or Evan, been involved if it is a complex discharge in regards to oxygen? So it's not for every patient, but really complex ones, and you want that support just so you don't get it wrong. Don't be scared to involve them in NDTs. Follow-up sleep study planned, booked within 3 months of discharge. Again, we've kind of chosen this number. If you can do it before, then amazing. If you can't, you know, it's not the end of the world, but just as a rough number of months. And then ensure that the respiratory care plan has litre per minute documented rather than FiO2 percentage to maintain consistency. Just then, you know, everyone's going by the same unit, so the same measurements. So the ventilators that don't have the integrated sensor, you know, it just makes it much easier and consistent. And that is everything. So have you got any questions? And thank you for listening. And I appreciate this PowerPoint isn't applicable for everyone who doesn't work with NIV patients.
Thank you very much, Emily. I think I found it very useful. I've noticed there's been a few pediatric patients as well starting to be in the neonatal unit a bit longer. So it's
Definitely.
quite useful. So,
Sorry,
yeah.
hi, Emily. Sorry, it's Kristen, one of the CCNs from Croydon. One of the safety checklists said within the first few days the baby is discharged, we should be carrying out a sleep study or sleep assessment just to see the compatibility of the oxygen. Is there like a limited number of days or a maximum number of days? I know it says a few, which is open to interpretation. So, because if we have like a baby on oxygen, for instance, that is sent home, we normally wait a week, let them settle kind of, and then carry out the sleep study. Is that safe, or would it be like advised to carry it out a lot sooner?
Yeah, I mean, to be honest, that does sound very safe. It was more so if the child was unable to go on home leave to test the equipment, to see what their oxygen saturations are, then it would be kind of required for them to have a sleep study relatively soon. We've said kind of the next few nights, but within a week would be fine. And this is at the minute, so it needs to be piloted, this checklist. So actually, these are all really helpful points because every centre is going to be different. So it's, you know, it's really useful to hear of people's feedback. So at the minute, it's not going to be an official checklist, but I think if we send it out, people can start using it, and then we can tweak anything that we need to do.
Yeah, perfect. Thank you.
Yeah, I will only take one more question so that we can move on. Yes, Catherine.
Oh, hi, Emily. Thank you. That's a really good presentation. Just going back to your last slide where you said it should be prescribed in litres rather than percentage. If you had done that with your patient, would you not have picked up on the discrepancy? Does that make sense? Because your discrepancy was to do with the percentage, wasn't it? So was there some documentation of the percentage, or was it the parents that picked it up?
Yes, sorry, yeah. So we were going by the percentage initially. So that's why it was really important that we were trying to achieve the 45%. And I think kind of this is how this has all come about. A bit of a caveat to that is actually, if we were going by litre per minute, we wouldn't have found this out.
Yeah,
so this is kind of where it's a really tricky one. And that's why I think kind of going forward, it's so important to check the SATs, but also to do the sleep study, because from, you know, the results that from the questionnaire, it would seem that actually parents have noticed their child has desatted. So actually, it's really tricky to know, but I think in terms of consistency for clinicians, litre per minute is probably easier.
Yeah.
However, it's not to be that we're not going to take into account the percentage at all, because actually that is still really important, and that is what flagged this issue.
Yeah.
So I think it'd be a kind of a combination of two, but in terms of the actual prescribing, litre per minute.
Yeah. Cool. Thank you.
Thank you again. Thank you very much, Emily, for your presentation. That was really useful. And as you said, just going to do some piloting on that checklist. And once it's done and it's been rectified, then we'll be happy as well. We'll be uploading it on the PLOG website.
Perfect. Thank you.
So our next presentation, do apologize to the Hillingdon team because we just delayed them because I know they've been busy. But so hopefully they've got somebody who's joining us. I'm not sure. Okay, you're here. You're gonna be presenting from your side?
Yes, I will be
Okay,
presenting.
yeah, I'll hand over to you. So we've got wonderful team from Hillingdon presenting about the work they've done. Yeah, I'll let you.
Can everyone see the slides? I just want to check.
Yes, we can see.
Amazing, thank you. Good afternoon, everyone. My name is Akhil, and today myself and Noor are going to be talking you all through Hillingdon Hospital's experience with their chronic lung disease babies who have been discharged with home oxygen. So if we go back to the beginning, we know that PPLOG was created because a lot of the literature and guidelines were just getting too old and outdated, And actually, we noticed that ourselves when we were doing the research, the literature review for this project, where we couldn't find any current literature published that documented a unit's experience with the home oxygen babies. So we thought it would be really nice to have a look at our own experience. So what we did was we collected 3 years worth of data. So we looked at babies that were born and discharged on home oxygen between mid 2019 to mid 2022. And then we analyzed this data and we found some really interesting insights from it, which we're really excited to share with everyone today. So without further ado, so over this 3-year period, we had 22 babies who were discharged on home oxygen. Now, I just want to mention a quick caveat here where for almost all of our analysis, we have looked at all 22 babies. There is just one small section where we will discuss the relationship between bronchiolitis and the time taken to wean off oxygen. And in that analysis, we just couldn't include any of the babies who either passed away from and weren't able to ever wean off oxygen or just hadn't weaned off oxygen. But on this slide, I think the really key insights come from looking at the 2 tables at the bottom. So what we can see here is that on average, the gestation of our home oxygen babies at birth is around 26 weeks, with a range of sort of plus or minus 3 weeks. And we acknowledge that it's not particularly common for 29 weekers to end up being discharged on home oxygen. But so just to clarify for this baby, they were a twin and was severely growth restricted and had pulmonary hyperplasia. So that's what ended up resulting in them requiring home oxygen at the end. And if we look at gestation at discharge, we can see that they generally tend to be discharged around 42 to 43 weeks, but there seems to be a much larger range, which makes sense. It's each baby will sort of develop differently on the unit, and that will affect discharge. So let's have a look on sort of a year-to-year basis. We can see that on average, about 5 to 6 babies are discharged on home oxygen each year from our unit. It's interesting to see that in 2019 and 2020, it was almost sort of half the number of, sorry, not 2020, 2019 and 2022. It was about half the number of home oxygen babies as 2020 to 2021. Now, we spent a while trying to figure out why this could be happening. And I think personally, actually, the reason why is the differences here is because of the way we sampled. We looked from mid 2019 to mid 2022. So it's likely that that's about 6 months of data on each end. So I think hopefully in the future, we will expand that to the full 2019 to 2022 period. And we should hopefully see about 6 to 8 in this region. So I'm just going to pass everyone over to Noor for the next section.
So hello everyone, my name is Noor. I'm one of the paediatric trainees at Hillingdon. Thank you, Aka, for that. So just going on to the next slide. So this is actually a reiteration of what Akil had said, and it's just a slide that shows bar graph of the number of babies who went on home oxygen. So the home oxygen baby stratified by gestation at birth. So as my colleague Akil had said, our average gestation for our babies who actually went home and home oxygen is around 26 weeks. We had a minimum, the range was between 23 weeks and 29 weeks. 7 of our babies went home on home oxygen were 26 weekers, and around 5 babies went home and home oxygen were around 27 weekers. Next slide, please. Right, and this is just another bar graph that shows the home oxygen babies that were stratified by gestations at discharge. Our average of babies who went home and home oxygen were around 43 weeks corrected, and our minimum gestation of our babies who went home and home oxygen was around 38 weeks, and just 1 baby went home and home oxygen was around 54 weeks of corrected gestation. Next slide, please. And so this is a slide that also shows the home oxygen babies stratified by oxygen requirements when they were discharged home. So around, we would say around half of our babies required 0.2 litres of nasal cannula oxygen. 16 of our babies, which is more than half of our sample size, went home between 0.1 and 0.2. A few of them has gone home on 0.3 to 0.5, and we just 0.6, sorry, where one baby just needed to go home on 0.6 litres of nasal cannula oxygen. Next slide, please.
So now that we have characterized our sample, we thought it'd be nice to show you some of the relationships that we've seen. So this graph really nicely shows that there is a relationship between the gestation of our home oxygen babies and the hospital. And we can see that the more premature a baby was at gestation, the longer the length of stay. And that does, that makes intuitive sense actually, where the more premature they are, the less mature their lungs are going to be, the more likely they are to have had complications whilst in the department. So the longer their hospital stay was going to be. Now this next slide is, it's the relationship we're trying to show is a bit harder to see, and it needs a bit of an eye of faith here. But if you just have a look at these red numbers, if we were to draw a line through them all, we can see that pretty much all of our babies fall on the left-hand side of this this line. And what that seems to suggest is that there could be some relationship between a baby's gestation at birth and how much home oxygen they get discharged on. And again, this does tend to, like, logically, this makes sense that the more premature a baby is, the more likely they are to be discharged on a higher concentration of home oxygen. And conversely, the less premature they are, the more likely they are going to be on a smaller amount of home oxygen. Unfortunately, our sample size just wasn't big enough to be able to show this more effectively. But what we can show quite nicely is the relationship between how long a home oxygen baby is in hospital and then what their home oxygen requirement is once they are discharged. And we can see here very nicely that the babies who had a longer hospital stay required more oxygen on discharge. And this links really nicely with the last couple of slides that I showed you, that and I'm sure everyone knows it from experience, and I think it's just nice to see it visually, that a very premature baby will spend longer in hospital and will likely require more oxygen on discharge, which makes sense with the physiological processes that they undergo throughout sort of in utero and also on the unit. Back to you again, Nor.
So the next slide is basically a slide that shows the relationship between our babies developing bronchiolitis and the effect on them weaning oxygen. So when we looked at our sample size, around 10 babies, which is around 45%, had acquired bronchiolitis. 4 of these babies, which is around 40%, had required more oxygen than what they were discharged on at some point. And none of these babies who did not acquire bronchiolitis required more oxygen. And generally, we looked at samples, the babies who acquired bronchiolitis took longer to be weaned off oxygen than those who did not have any bronchiolitis at some point. Next slide, please. And this is just a slide that shows the types of bronchiolitis when you look at the data that our babies had acquired. Just bear in mind that all of our babies, 100%, had received palivizumab over the course of winter. If you look at the data, 4 of our babies, which is around 18%, has acquired clinical bronchiolitis with no bucks. 3 of our babies, which is around 14% of our sample size, required RSV bronchiolitis. Another 18% had acquired rhinoenterovirus bronchiolitis, and 1 baby's acquired adenovirus bronchiolitis, and 2 babies had COVID. Next slide, please. So this is a slide that basically concludes our data analysis. So from our data, we were able to show that there's a relationship between the development of bronchiolitis and the time taken to wean off oxygen, and the development of bronchiolitis and the requirement for more oxygen at some point. As also, as my colleague had said, the length of stay in hospital and oxygen requirement on discharge, and the gestation at birth and the length of stay in hospital. So the things that we're currently working on within our department is we're currently taking on feedback from parents, which will help us develop things further. We're also doing ongoing training of the staff based on recent PPLOG guidance, and we've also done a chronic lung disease home oxygen video, which we're going to show on our next slide. And from this, we are planning to actually try to do a publication of our findings, and we're hoping to do an extension of our project to actually either Northwest London or Pan London. Yeah, the extension. Actually, if you just want to go to the next slide and show the video.
Should we wait before we show the video, you think? Should we take some questions first?
Yeah, I was just about to, yeah. Thank you very much for that wonderful presentation. Yeah, I'll just ask if there's one or two questions. That was a great presentation. I think you've stunned everybody to silence.
Thank you both for presenting. I'm Dev, I'm one of the consultants at Hillingdon. Can you all hear me?
Yes.
So we're very aware at Hillingdon, and our community nurses are here as well, that a lot of what we're presenting probably doesn't sound like rocket science, and probably the experience that most of you have had in a DGH, for those of you DGH hospitals on the call. But we just thought it would be nice to actually quantify the experience we've had, and we'd love to kind of see the experience other hospitals have had. So sorry if it sounds very basic what we presented, but we just wanted to collate and see what we found when we put our data together. So thank you for listening, for those of you that were here, and big thank you to Akhil and Noor for their hard work on this, and Diane and Chloe, who are our community nurses on the call as well.
Wonderful. Thank you. It was very informative, and I think that's a good insight of what's happening and probably having that deep dive. Before we play the video, because I'm mindful of time, and then I can allow people to watch the video until right to the end, as people will be leaving probably for other meetings. I just want to ask 2 or 3 questions so that I can get a sense check about this meeting, and then we'll play the video, and then people are free to drop off as they're watching the video when it finishes. So first of all, I think we spoke about so I've just put a thing in the poll. So I just want people to answer. So we spoke about the service specification at the beginning, me and Moni. We just want to understand, is it something that people think will be very useful within their local area? So please just click on that, your options, and submit. Okay. People are still responding. We got about 50 people on the call, so some probably didn't hear about it at the beginning. So we got more yeses and some maybes. Okay. Wonderful. You can continue responding on that. I just want to as well ask another question. Okay. So they will be all in your chat box as you're putting them, because it just helps us to give us an idea of how if this was useful or not useful, and how you felt about it. So just continue submitting on that. And one more before we play the video. And that means the video will be playing, and feel free as you watch the video when it finishes. And we'll ask as well our Hillingdon team if you're able to also put that link of the video in the chat box for those that would like to share it as well within their local area. Will be quite useful. And I think that's it. And yeah, I've just put one more and then we could play the video. Okay, while you're doing that. Yeah, are you happy to play the video now? And then people could just go in the chat box and put their comments on those. And thank you very much to everybody joining us this afternoon. Thank you for joining the PLOG winter webinar, and we hope to have a face-to-face or something soon. And thank you to all our speakers, really. I really appreciate you taking time in your busy schedule to come and present. So we really appreciate. So yes, you could play the video and then people can watch.
Just let me know if you can hear it or not. Is there sound?
No, you might need to tick the sound.
Yes, okay, I'll do that. I may have not done it last time. I will resend. Can you see the video now?
I can see it, yeah.
And can you hear it now?
Hello everybody, and welcome to our video on chronic lung disease and home oxygen. My name is Deb, I'm one of the consultant paediatricians and I work mostly on the neonatal unit. I'm also the lead for home oxygen. In my absence, of course, any one of my colleagues will be able to support you. If your baby's going home in oxygen and you live in Hillingdon, I will be your named consultant. If you live in the Ealing borough, you will be allocated an Ealing paediatrician. Over the next few minutes, we hope to share with you the journey that you're about to embark on for your baby going home in oxygen, and actually a few real patient stories to help you understand what's about to happen.
When babies are born very preterm, often they may need a fair amount of breathing support or oxygen when they're born. If they're still needing that support when they're 36 weeks corrected, your baby has got chronic lung disease. Before your baby comes home in oxygen, and that decision is made for home oxygen, we would have done various different tests in order to make sure that your baby is going home on the right amount of oxygen.
Hi, my name is Diane. I'm the clinical lead of the Community Women's Nursing team in Hillingdon. We've had a referral that your baby's going to go home in oxygen. Our team of nurses will be there to support you through this long journey. This will be an anxious time for yourself and your family. We will be there to answer all your questions. We will visit you on the unit to go through the process with you. You will have the opportunity to stay with your baby overnight before discharge. We will go home and visit your house to check that the oxygen will be safe to be placed there. Once that's been agreed, the consultant on the unit will order the home oxygen and the company will deliver your oxygen.
In the preparation of your baby going home in oxygen, usually I will sit with you and with the community nurses, possibly with the nurses on the neonatal unit, out of the clinical environment. This is usually to give some time to you as a family to understand what it actually means for your baby going home in oxygen. This conversation will involve some of the pre-checks, including the consent forms, talking through some of the oxygen cylinders,
and most importantly, the kind of support that you will all receive from our community nurses who are absolutely brilliant. What I will also cover, along with the community nurses, is the process of home oxygen weaning, and what was to happen in case your baby was to become unwell and need more oxygen. We would also cover things such as when the home oxygen will be removed when your baby's been weaned into air.
The day you're discharged, a community nurse will come and visit. She'll go through again all the things we covered before. She will talk about the oxygen, changing the tapes, the prongs and the cylinders. She will talk to you about immunisations, weight and growth. We will visit you as often as you want in the first week. We will do a baseline check in oxygen before making plans on weaning the oxygen.
Following discharge home, usually within 1 or 2 months, you will have a scheduled appointment date for your baby in my chronic lung disease clinic, which I normally run on a Tuesday afternoon. Prior to that appointment, I would have had a few conversations with the community nurses about weaning home oxygen.
So Logan was born at 25 weeks and he's been home for roughly about 7 months now. He's 7.5 months corrected. And in that beginning bit when we first came home, it was very, very tough to do. But I think my biggest challenge was I didn't anticipate him to be on oxygen for so long. He had some setbacks. He had a bout of pneumonia and went back into hospital and then had to come back out on higher oxygen. And he had a plateau in weight, so we had to stop the weaning of the oxygen. And I think those types of setbacks are really hard to deal with. But you have to stop and remember, you know, he's going to get there eventually, and you do have those days where it gets frustrating, but he is developing, he is getting there. You can look and think back to when he came back and his bounds forward, leaps and bounds.
My name is Chinwendu and I am mom to Udochukwu Maduka looking at you right now. Udochukwu arrived as a surprise at 26 weeks. It's been a journey of anxiety, it's been a journey of fear, it's been a journey of unknown, especially when we were told that she had to go home on oxygen. I panicked. I tried everything to make sure that she doesn't go home on oxygen. I made sure that, I told them, try one more week, try, because I just was afraid of what to expect. I thought they were going to come to my house with one big machine, one big tank. How was I going to cope? Will I be able to go about with it? But she had to go home on oxygen on 0.2 liters. And I had fantastic support from the hospital team. The nurses were there to guide me on what to do and what not to do. And the first surprise I had was when the oxygen was delivered. I was looking to see a big tank, but actually it was just a small tank. And then I had a smaller one that actually I could take around, and I was shown how to use it. And I thought, this is not really as hard as I thought it was going to be. It was a bit challenging at the beginning because I wouldn't sleep. I was afraid of, the clips coming off her nose. I was afraid of what would happen if it went off for more than it's supposed to be. But eventually, here she is. She came home February after 15 weeks in the hospital, and she was on oxygen for another 3 months at home.
So that brings us to the end of this video. We really hope that watching this video has given you some sort of idea of what lays ahead of you when you go home with your baby in oxygen. We do understand as a group of professionals that going home with your preterm baby for the first time is really an anxious time. And we can understand that going home in oxygen on top of that has an added degree of anxiety for you. But we hope during this video we have shown you that as a team of doctors and nurses in the hospital and importantly, your community nurses and all the therapists that you'll see in the community. You're not on this journey alone, and you will be well supported. Thank you so much again for watching this video, and a big thank you to everybody who's contributed in making it.